So I'm going to talk to you about 15 minutes. I think for most of the time, we like to engage in a conversation with all of you as to what do you think about whole body MRI and what do you think about whole body MRI for cancer screening. So to kick off, the question is why even bother using whole body MRI at all? The thing is that whole body MRI has evolved into a technique that we can apply to look for areas of cellular abnormality throughout the body. It doesn't use any ionizing radiation, so unlike PET and CT, we can safely repeat it yearly or less frequently or more frequently if we wanted to. It can be safely used in the younger population. So typically some of the younger population we're thinking about maybe in the pediatric group, if you have a genetic predisposition syndrome, or even in people in the midlife, say between the ages of 30 and 40. As I said, it can be safely repeated. And we know that it is highly sensitive for cellular disease or malignancy. So the key to whole body MRI technique now is what we call DWI, or diffusion weighted imaging. This is already implemented as a standard of care technique in most MRI centers. And what we know that if you apply it over a specific region of the body, we can use it to detect sites of malignancy. In this example here on the left, we see evidence of liver metastases. Here we see area of thickening in the lower esophagus, and here we can see a pancreatic cancer being depicted. So cellular disease on diffusion weighted imaging will appear bright relative to the background tissue that becomes dark. So you have this natural contrast between areas that are abnormally cellular and the background that is often less cellular. So evolving this technique from a single region to multiple stacks, and we can do this analogous to the coverage for a PET-CT that is typically from the vertex to the mid-thigh level. We can begin to render these images. In this case, we use what is called a maximum intensity projection image, and you can see that these images begin to look like PET imaging, but they are not PET imaging because the biological basis of this contrast that we see is not due to tracer uptake, but a map of tissue cellularity. And as I said, because the background tissue is so well suppressed, areas of cellularity is enhanced by this technique. So whole body MRI performed for screening now typically takes about an hour. What we do is that we perform sagittal imaging of the spine. We perform diffusion scans using two different diffusion weightings. We call them weightings. So B50, B900 are just increasing amount of diffusion weighting. We perform some anatomical images, typically T1 and T2 weighted scans. From the diffusion scans, we can calculate a cellularity map, or an ADC map, which stands for apparent diffusion coefficient. And we also perform FLAIR imaging of the brain to look for any intracranial abnormality. We also perform imaging through the lung, although typically MRI is not recognized to be very sensitive for lung disease, but nonetheless, we can see pulmonary nodules up to about 1 centimeter in size. And what we do know is that this technique together is very good for overall detection of cancer or cellular disease that is more than 1 centimeter in size. Why are we confident that we can use whole body MRI as a means for cancer detection? So if we look at the meta-analysis of 13 studies involving over 1,000 patients that compared whole body MRI or whole body diffusion weighted imaging and conventional FDG PET-CT for the detection of primary and metastatic malignancy. So these are patients with known disease, and we subject them to comparing whole body MRI and FDG whole body PET-CT, you can see that the diagnostic accuracy, the pooled sensitivity, and specificity are extremely similar, meaning to say that whole body MRI using diffusion weighted imaging perform as well as FDG PET-CT in the detection of malignancy. So not surprisingly, where whole body MRI has first appeared for cancer screening are in patients with so-called high-risk genetic predisposition syndrome, such as Lee-Fraumeni, these other syndromes that I'm not going to describe here today, except to say that if you look at the American Association Cancer Research guidelines, they are now clearly recommended in these conditions. In particular, we know that Lee-Fraumeni syndrome with germline mutation of the so-called p53 gene, we know that the lifetime risk of cancers in these individuals is as high as 70% in men and 100% in women. So screening seems to make sense. And if you look at the prevalence of cancer in this sort of high-risk individual, they are described to be varying between about 4 to as high as 32%, but most people acknowledge that the incidence of prevalence will be in the region of 10 to 15%. And many of these tumors are unusual tumors. They are not readily screened, except in the case of breast cancer, subject to normal screening methods or tests. And therefore, it makes sense. If we look at the survival of patients over a 60-month period between individuals who are screened, which is represented by the red line here, and those that are not screened, represented by the blue line, we can see a clear separation of survival, meaning patients who are screened by whole body MRI perform much better in the long-term outcome compared with those who are not screened. And for that reason, international guidelines now recommend whole body annual whole body MRI for cancer detection in these individuals. Now, clearly, if we are going to be able to screen for cancer in these high-risk population, then the question is that, can we actually offer it for screening in the general population? The rationale of this is that, well, it could potentially be added to a health check. It is radiation-free with no significant side effect. It has high sensitivity, and also from studies, we know it has high patient acceptance. However, we advocate, and Anwar and I are very passionate about it, that this should be performed, if we want to undertake this, it should be performed in centers with good experience in whole body MRI that Anwar and myself can provide, but we really need good clinicians to be co-partners in this screening program, because we require detailed clinical history to be taken. And most importantly, we need incidental findings, which are very, very common in this group of patients, to be appropriately managed. So what's the reason why we might want to advocate thinking about using whole body MRI to screen for cancers? Well, these are the top 10 cancers that we can see according to Cancer Research UK and elsewhere. And you can see that the top 3 cancers widely seen in the Western population, breast in men and breast in female, and prostate cancer in men, lung, colon, and rectum, these all have their own recognized screening program or technique, albeit prostate screening is just emerging. However, within the top 10 cancers type, we have cancer of the urinary bladder, kidney, liver, and the rising star of cancer, which is pancreatic cancer, for which there are no advocated screening program, and these cancers typically present late when there is very little to be done except palliative management. If we look at 10 studies reporting the findings in more than 6,000 patients, we see that the findings are quite startling, that amongst the cancer that they detect, these are the ones in the top 10 list. And in fact, this has been an experience of the screening program at Phoenix as well, where we begin to detect renal cell cancer, unsuspected pancreatic tumor, for example. And these are things that we are normally not be able to detect using conventional screening programs. So if we look at here, a summary of general whole body MRI screening from 12 studies involving over now 6,000 patients, there are a few interesting findings. First, abnormal findings are very, very common. So if you screen a normal population, 94% of them would have some sort of abnormal findings. However, many of these findings are going to be benign. So the thing is, the balance is that if we do whole body MR screening, we need an appropriate pathway to manage these incidental findings. Of those that are so-called reported abnormal, only about 30% may require further evaluation, if at all. And those that are confirmed malignant is in the region of 1%. So in the general population, we're looking at the potential of finding 1 to 2 cancer patients in every 100 patients screened. So this is a summary of what we expect to find using whole body MRI in the general population setting. So 1 to 2%, and then incidental findings being very common, but remember, the majority are benign and do not require further tests or follow-up. So one of the things that we also consider using whole body MRI to screen is that whether there are any significant psychosocial impact of the screening itself. So in this relatively modest study of about 500 patients, about 10% of patients said that they had strong distress while waiting for the results. 30% had moderate to severe distress after receiving the notification. And what was interesting was that there was a strong disagreement between the subjective and radiological assessment of the significance of the finding. But really interestingly, 96% of them were satisfied with their MRI studies. And if you follow these patients up over a period of time, studies have also shown that there's no difference in the quality of life between participants and non-participants using whole body MRI screening. So that brings us to present to you what Anwar and I, this is something that we published together using what we call an OncoRat system for whole body MRI screening reporting. And this has really evolved through the fact that incidental findings are so common, and we felt that it was really important to be able to communicate the relative risks of these findings back to the referring physicians so that appropriate action can be taken or not taken. So very simply, we communicate any finding on the whole body MRI as we read them into 5 categories. So OncoRat 1 is a totally normal examination, 2 benign findings, highly likely, 3 benign finding is likely, and 4 and 5 are where malignancy are likely or highly likely. So if somebody is referred to us for screening tests and we report a finding that is OncoRat 2 that is benign or highly likely benign, these patients generally do not require any further follow-up, whereas an actionable finding is usually that of 4 or 5, and the category 3 can be either follow-up or subject to a further test. So examples of Oncoret's 2 findings include cysts in the liver, hemangiomas, kidney cysts in the kidneys, and uterine leiomyoma. And as I said, if we give a category 2 finding, no further follow-up is required. And that really, I think, helps clinicians to manage the potential deluge of incidental findings that can be unveiled by the whole body MRI examination. So this is also a flow chart that also tells us how we want to potentially manage these findings according to Oncoret score. And I'm just going to focus on the general population here because this is the area that we're probably more interested in this evening. As I said, if we give an Oncoret score of 1 or 2, the risk after whole body MRI is low risk, and we generally say that no follow-up is required. If the score is 1 or 3 in the general population, this is intermediate risk, and usually we will recommend active follow-up, either a repeat MRI, a targeted MRI, or some other test to clarify the MRI findings. If it is a score 4 and 5, it is considered high risk, and further investigation is absolutely required. And we really want to work with good GPs and referrals because we really don't want anybody in this high-risk category to fall through the net and not receive the attention that they actually absolutely need. And at the same time, to reassure patients in the category 1 and 2 findings that no further action is actually required. And in so doing, bring a certain confidence to the screening process and also confidence in the significance of the test results that we present. So just a couple of findings. This is an example given to us by Professor Giuseppe Petralia, who has also a large screening center operated in the north of Italy. So in this example, we see that there is an incidental exophytic mass from the right side of the bladder. The patient was referred to cystoscopy and was proven to be a papillary urothelial tumor, a very small low-grade tumor, 7 millimeter in size, that was excised, and the patient is well. So here is another patient with a 63-year-old woman, and this lady was screened at Phoenix in the early days of a screening program. And here we see, although we say MRI is not particularly good in looking at the lung, we see that in this example here, there is a lung mass that was given an Oncoret 4 finding, referred for chest CT. And incidentally, there was also a second lesion that was in the pelvis within the uterine cavity. So this was thought to be potentially an endometrial polyp, and she was appropriately referred to the gynecologist. So in summary, I just want to outline that in this short talk, I have shown that whole body MRI is a highly sensitive technique for detecting disease or tumors across the body. It provides an opportunity for early detection of cancers for areas outside established screening programs. However, we need to operate with good clinicians, referrals, because a careful clinical history would provide important information regarding cancer risk and for corroboration of the imaging findings. Incidental findings are extremely common in this group, but the majority requires no follow-up, and therefore we use the Oncoret score to help support decision-making. The indeterminate and suspicious findings should be managed accordingly, and we always believe that we are only part of the patient journey, and clients should be managed long-term by responsible physicians. So I'm just going to end there now and open up to a conversation with all of you, with myself and Anwar.